Here at the Sagicor Cave Hill School of Business and Management, located at the University of the West Indies Cave Hill campus, we meet the needs of the upwardly mobile professionals. Our business school functions in an evolving global space where the need to have that competitive edge distinguishes you as a professional. Our academic curriculum offers a variety of programs that gives you that edge. We offer our students a doctorate in business administration. Then, there's our executive masters in business administration. Our Sagicor Cave Hill School of Business and Management is for you. Enroll now.
Good morning. Welcome to Friday webinars at the Business School, UWI Cave Hill. My name is Marjorie Wharton. I am the Strategic Business Services Director and Clinical Faculty with the Sagicor Cave Hill School of Business at UWI Cave Hill campus, and I'm your host for this event today. Our topic is COVID-19. We are discussing the virus, threats, and impact. We hear a lot about what is happening all over the globe as a result of the novel coronavirus, COVID-19. We've recorded more than 3 million cases worldwide. Every news network across the world is talking about this virus and the impact that it is having on all of our lives. New words have been added to our everyday vocabulary, things like PPE, contact tracing, and herd immunity. Some of us spent hours listening to medical practitioners, public health officials, and political leaders offering their perspectives, their advice, and their guidance. Yet there is still a lot of misinformation, misunderstanding, and uncertainty around the entire virus and this entire situation. We know that the best way to calm much of our fears and our anxieties is to share information and build knowledge about what is happening around us, what the future is likely to hold, and what we should be doing about it. And so here we are today. Our panelist for this session is Dr. Kenneth Connell. He is a highly motivated medical professional, guided by a passion to engage various health communities to improve health outcomes locally, regionally, and internationally. He is an associate professor in clinical pharmacology at the Cave Hill campus of the UWI, consultant internist at the Queen Elizabeth Hospital in Barbados, governor of the American College of Physicians, Caribbean chapter, USA Center for Disease Prevention and Control, CDC, international consultant, Global Hearts Program, president of the Heart and Stroke Foundation of Barbados, the chairman of the Barbados Drug Formulary Committee, and a member of the COVID-19 Task Force. His interests include health system strengthening, public advocacy in the social determinants to health, and workplace wellness. Good morning, Dr. Connell.
Good morning, Marjorie, and good morning to all the listeners out there on our live stream. Thank you for joining us on a bank holiday if you are in Barbados.
Okay, now this webinar is scheduled to run for 1 hour and 15 minutes. Our discussion is going to take 2 parts. First, we're going to look at the virus and try to develop a clear understanding of the situation. And in the second part, we're going to explore what the future holds and what we should be doing to navigate it. As our panelist is sharing his perspectives and insight on the topic, we also invite you to ask your questions. On the screens, you will find the control panel, which will give you an option labeled Q&A, and you may use that function at any time. You may also use the option of chat. As we go along, our panelist will select and respond to as many of the questions as he can. Now, to get us started, I'm going to invite Dr. Connell to lead us off with his opening comments.
Well, thank you very much. And despite your very long introduction, which made me felt like I have no time to even look at anything else but hypertension, I did have a lot of time over the last few weeks to engage in this novel virus, not only because it affects patients with or people living with hypertension, but because as an internist, it's of course an interest to me. And so I'm very happy to deliver this presentation. But more importantly, I'm happy to hear your questions. I have to admit that some of the responses and some of the myths that I've chosen in this presentation, I really do owe it to first of all, my medical students, because they were misconceptions they had, and also my patients. And so with your permission, I'm going to get started. So there is a brand new pandemic. And I said new pandemic, and you probably might say, well, can you have an old pandemic? I suppose you can have an old pandemic if it reoccurs in a second wave. But by and large, pandemics are new. And that's the reason they become pandemics, because the society, the populations that they've entered have not been exposed to them before, or have had minimal exposure. I have no financial disclosures, although who knows, if I give this talk next year, hopefully I might have some. And so enters SARS-CoV-2, the virus that causes COVID. I'm just going to share some facts, just really to get the audience thinking about questions you might have. And this timeline is not unusual, and it's known by everyone, mainly that this virus started in Wuhan, China, in a meat market, when we had the first case isolated back in, reported 27 cases in December 31st of this very strange pneumonia. And I believe it was actually reported by a dentist in Wuhan, who subsequently, unfortunately, passed away with the virus. Now, healthcare professionals like to report these things that are unusual. And so this presented an unusual cluster, and I'm using my words carefully, cluster of people with this pneumonia that did not seem to either progress by the natural history of a viral pneumonia, or really did not respond to what we would call supportive care. And the spread has been phenomenal. And the various timelines here, I'm not going to go through them in much detail, but suffice to say that there's some basic things that I want the audience to consider when talking about this virus. First of all, it's novel. It's not novel to the world, it's just novel to us. And human beings, we think we're special, and if it's not part of our health or our illness, we say, well, it's new, but it's really novel to humans. And that's because the virus has probably been around for a long time in other animals, like bats and other species, I should say, in the environment. These types of infections are known as zoonotic infections. Zoonotic infections are infections that live in a host animal other than the human species. And therefore, some examples of these might be the avian flu, which has crossed the barrier and has entered the human population. But other common things like rabies virus, those things occur in animals, but we are not carriers of those viruses. Now, why would a virus suddenly leap across from one species into another is a question that I think we must solve, because it will determine how future outbreaks might be halted at an earlier stage. And well, let's look at one myth. This is created in the lab, and this virus is too different not to have been created in the lab. Well, I'm not sure whether it is created in the lab or not, but what I would say is that there seems to be credible evidence that it could have occurred naturally. The lab creation is comforting to us because it makes us feel as if we were in control of what happened. But we also live in a world where things are out of our control. And here is one hypothesis as to how this might have happened. This RNA virus, as I have up on the screen, lived in the system of the bat. So the bats are all carriers in Wuhan. And of course, Chinese might have a different relationship with bats than we do. But somehow, the virus was able to not just infect a human host, but also to transmit from human to human. One theory behind that is that with the evolving climate change that has occurred in the last decade or so, the microsystem of the bats, or if you want to call the environment within the host bat, has changed slightly, such that the core temperature has changed, and maybe other chemicals in the blood of these bats have also changed. Now, why is that important for someone who doesn't really study bats for a living? Is that when that happens, it means that the virus can now change its behavior such that it either multiplies faster or it's able to become more virulent or more infectious, and more importantly for us, leave a bat host and enter a human host. Now, then it comes back to who caused this. Is it created in a lab? Because if it is climate change, then we are probably the main culprits for climate change. And you could actually say, well, you know, humans might have brought this on ourselves. But we're far too sophisticated to place blame on ourselves at first. Of course, we know it's contagious. And I want you to put yourself in the seat of a virus. Now, if you were a coronavirus, you would not want to have a vaccine found within a couple of weeks, would you? Or you wouldn't want to be able to just infect one or two people. That would be kind of stupid as a virus. You want to try to infect as many people as possible. That's your goal. You don't necessarily want to kill your hosts. I don't think that's the intention. You just want to get from person to person. So you have to be contagious. It can't be that you have to have an organ transplant in order to get this virus, because not many of us are getting organ transplants. But you have to be able to move from one person to another. The other thing is, it's kind of helpful if you have some people walking around with you inside of them that don't really know it or don't express symptoms, because what they can do, they can now spread it to more people. And these are the asymptomatic carriers. So contagious or infectiousness and asymptomatic carriers are good if you are a virus. You also, as I said, might be lethal, but you don't want to be too lethal. Let's use the example of Ebola, which had a mortality rate that's much higher than SARS-CoV-2 or novel coronavirus. What happened? It burnt out. There wasn't a pandemic of Ebola because the people who became infected died. And unless they were in certain contact with healthcare professionals or other people, they weren't well enough to spread the virus. So that's a problem if you are too lethal. Now, you want to also have some impact on vulnerable groups. So classically, the influenza virus that attacks us every year without much hype on CNN and live coverage 24/7. Influenza attacks us every year, and it really does knock out vulnerable groups. Those people who have altered immune responses for whatever reason, whether they are on medication to do so, whether they have chronic non-communicable diseases such as hypertension, diabetes, or whether they just genetically have a weaker immune system, which is linked to certain conditions as well. So these are vulnerable people. They're at higher risk for most infections, so it's not really surprising that these people succumb more and have a higher mortality rate. But what about a bizarre immune response, not immune response, although immune sounds cooler as well, but a bizarre immune response? What about that? Well, you kind of want your attack system to kill the virus, but you want your attack system to kill only the virus and not to attack it yourself. We know that our immune system is not perfect. It's not the perfect army. It can somehow get mistaken by viruses that are camouflaged to an extent that they aren't recognized as foreign, and it can start to attack the host as well. The virus kind of tricks the immune system, or the immune system is tricked for some other cause. For instance, in systemic lupus, this is known as an autoimmune disease where the virus is attacking itself. Sorry, the organism is attacking itself, and it does so in a very innocent manner. Now, I mentioned in a previous presentation that it seems like COVID-19 is really a twofold event. Maybe there is a battle, which is this battle between virus, and that's the usual response, immune system fighting virus, and usually immune system wins, but then immune system becomes strict and acts bizarrely, and then a war starts, and we are not really doing very well at the war, even though we might have survived the battle. I hope that makes some sense. Okay, so here are the statistics up until 2 a.m. when I was up looking at CNN. It's impossible to look at CNN and not see these numbers. So more than 3 million people are infected. And to put things in perspective as to who is touched and who is not touched, this virus, although it does discriminate somewhat, touches everyone. Well, let's look at some of the other myths that have evolved. This is not a Black people disease. that was one of the earlier myths that probably caused a lot of the higher mortality rates that we're now seeing in the Black African American population, because they reacted to the public health measures at a later stage. To be quite honest, when the initial reports came out of China and I heard what was happening, I was probably part of that conversation with, oh, you know, thank God it's not killing Black people. And we as humans want to kind of segregate ourselves as a protected group. Thank God it's not killing younger people because, well, I used to be young at some point in time, you know, and therefore I'm not at risk. But the fact remains that although vulnerability is directly linked to risk factors like hypertension, diabetes, obesity, any disease where your immune system is not working at 100%, vulnerability is also linked to your immune system, which genetically may not behave the way it should. And so you have reports of young, healthy, athletic marathon runners who get this viral infection and just cannot beat it. It's not that they have a weakened immune system or they have an underlying disease, but their immune system just cannot get past it. And even if it gets past it, it then overreacts. And this seems to be a problem in these patients. This 80% isn't the amount of people that are infected by COVID, so don't have a panic attack. But I will tell you what it does represent. It represents the disease burden for non-communicable diseases in low to middle income countries, according to the World Health Organization. This is not something that we should be proud of because, of course, we're part of low and middle income countries. This is another vulnerability at a population or regional level, where you have countries that are susceptible based on their geography and the high NCD burden, which is a risk factor for COVID. But they're also vulnerable in terms of their economies and how they're able to respond. For instance, we can't just suddenly create 1,000 ventilators and scatter them throughout the region. In a few months' time, we will be faced with another climate change phenomena, the hurricane season, and budgets may have to be shifted in that direction. Barbados is part of an IMF plan, and of course, we do not have that financial flexibility to respond as we would like. Our health systems are therefore not as agile. But in defense of our health system, we can see that even the most sophisticated health systems in the north were not as agile to respond because this disease is expensive to treat, and therefore vulnerable economies are at high risk. And what I've just shown here is just some of the mortality rates of some of the common things that we might look at. So if you look at up here, MERS, bird flu, and Ebola have much higher mortality rates, and the horizontal x-axis is just showing the average number of people infected by each person, which is referred to as the infection rate or the R rate. So if you look at chickenpox, for instance, now I like to use the chickenpox analogy a lot in SARS because if someone walks into a room with chickenpox, especially if they're at the point where they have the respiratory symptoms, or even if they're at the point where they have the vesicles or skin lesions that are healing, and you are not immune to chickenpox, so you haven't been vaccinated. I know everyone on the call has had their varicella vaccine, but if you are not immune, then you more than likely will contract chickenpox. I mean, it's really that infectious. Luckily, SARS isn't. And so we have a problem with an infectious disease that is both infectious, but luckily, look at where chickenpox lies. I mean, it doesn't really have a high mortality. So if you're anywhere up here, you're highly infectious and you have a very high mortality, then that could wipe out a population because the usual public health measures are not going to be as effective. I've just given you a schematic or infographic, as I am told by my friends in media, showing in terms of the R0 scale. Now look at H1N1. It's about 1.2. So one person is infected 1.2 to 1.6 people. Look at SARS. So I guess you'd have to call it SARS-1. looking at the one infected person infecting about 2 to 4 people. Look at MERS. MERS, one infected person infects on average a lot more. These data are taken from South Korea, and COVID is somewhere between 2 and 3. You can't infect 0.5 of a person, but between 2 to 3 people are infected on average by one person. Now, what you're trying to do in your mitigation measures, and this is especially important for us here in Barbados and for some of our colleagues joining us in the rest of the Caribbean, is you kind of want a one-on-one infection rate where one person infects one person or less than one person. Because if you're infecting more than one person, even this 1.2 over here for H1N1, what that means is that your curve, the curve that everyone just knows about, even my 3-year-old godson said to me, "How are we doing with the curve?" He doesn't know what the curve is, but he knows it's important. So that kind of influences the upslope of your curve. Because then you can suddenly take off. 100 people then will infect 1,000 people, and then and so it's exponential growth that occurs. That's really why these isolation measures and being at home on lockdown are so important, because it prevents that from happening, and it's an intervention. Now, I've only shown you this table here because I know that there's been a lot of controversy in Barbados and in at least 2 other neighboring Caribbean countries, especially when reports are given in the media and usually the daily basis. How can we not have community transmission? Are we not a community? What do they mean by clusters, kind of thing? So here's the WHO definition. It's very precise so that we can compare data from country to country. Of course, category 1 means there are no cases. And we were at category 1 at some point in time. Some may question we may not have actually known when we were truly at category 1, but we were there at some point in time. 2 means sporadic cases. So countries, territories, or areas with 1 or more cases that are imported or locally detected. For Barbados, this was really by imported cases, people that traveled here who were asymptomatic, again, the asymptomatic carrier. They came to another country. This is the smart virus. It doesn't have to buy an airline ticket. It just infects someone who is well enough to travel, and it can spread across a geographical distribution. Those are sporadic cases. Now, where we are at now, hopefully, I say hopefully, and some people on the call may know why, is clusters, or we have a cluster which has been found in an agency, a government agency in the country. There's also a cluster of cases in a telephone center in Jamaica. And clusters usually occur because this is where people are in close proximity. Knock on wood, for instance, if Cave Hill had a few cases, Cave Hill would be the perfect environment to develop a cluster of cases, like an HR department, because people are coming to work. And of course, they don't remain at work. They can go home and infect their families and their friends. So clusters then can occur. If you have several different clusters and you have a large number of cases, and there's no link between how disease is transmitted, then you have community spread. So I know that some of the people on this call and some of my colleagues are very concerned at the fact that our last case that was identified, case number 81, I think it is, there doesn't seem to be a contact link to this person. But not having an obvious contact link may just mean that we haven't been able to identify the contact at that level. All right, so here's some other things that we already know. And this is relating to our behavior as people rather than the virus itself. There are race and class disparities. These are especially important in places where Black people are in a minority group or they are minority races. In the Caribbean, there are also minority races, but other types. But here are some things that are characteristic of us as a race. Historically, we have mistrust of the healthcare system. So this kind of was created in the lab, or this is a plan to really just try out a new vaccine. And because I don't trust those people in the healthcare system. Now, this isn't completely unwarranted because historically, we have also been the target of abuse in terms of research and certain biases against us in the health system. And some of these still exist. Maybe not to the extent before legislation was put in place to prevent them, but some of them still exist. We also are a believer in ethnopharmacology. And that's just a way of saying we like to know that the things we use to treat are naturally occurring substances. As a hypertension specialist, part of the early part of my consultation with most patients is going through a list of all the herbal products they've tried. So they come for a big bag and say, look, what do you think about this bush? Can you tell me how bay leaf tea is going to help me? Can you tell me how all these different substances are going to lower my blood pressure? Of course, I'm not an ethnopharmacologist, so I can't comment on it. But I know that this is an oral tradition, and I know that you're going to trust your grandparents and your great-grandparents a lot more than you're going to trust a stranger that you've just seen for 5 minutes in the office telling you to take a tablet for the rest of your life. So we have to understand that. And that would kind of explain why the reaction by especially the African American population and the Black Caribbean population is going to be quite different from other ethnic groups. There are also socioeconomic factors, employment, the environment. There's institutional implicit bias, which maybe I might get into, depending on whether you're interested in hearing more about that. But I think as a healthcare system, we also have our implicit bias against patients that present to the healthcare system. For instance, in terms of non-communicable diseases or acute presentations, I mentioned to a colleague recently, chest pain coming to the emergency room, it might be treated differently depending on if you're a man or a woman, or whether you're elderly or younger, or whether you appear to be of a certain socioeconomic status. It is not a bias that is predetermined, but is very unconscious, and therefore we might be doing this without knowing it. But the question arises then, how do we know that we're doing it if we're not measuring it objectively and if we're not being audited? I've already pointed out the disproportionate NCD burden, and if the one thing that COVID has done, it has magnified the epidemic of NCDs. So this is really a pandemic in the midst of an epidemic, and the NCDs have had a poor trajectory in our region. And of course, my next point, although we think we're one big, happy, multiracial Caribbean, we possibly are not. And so the points of classism versus justice and equity are things that are going to be unmasked, and they're things that they are the perfect opportunity for Caribbean governments to look closely at, to make sure that we have kind of not leveled the playing field, but made the playing field a fair place for every citizen in our region. And the vulnerable economies I've also mentioned. So what are we learning about the COVID-19? As I said, its behavior is completely different. It does have a bias to certain people who are vulnerable. It also seems to attack every single system. I mean, if you're following the news, you would kind of think, well, what else can it cause? I mean, you get a list of symptoms today, tomorrow, or even next week. You get 3 more symptoms added on, and then 2 weeks from now, another set of symptoms. And what this really says is that we don't really know the extent of the disease description or the symptomatology of the disease. So breathlessness and cough was thought to be a cardinal pair of symptoms, as well as a fever. We know that many people now don't have the fever. We also know that other things can be associated with it, such as a loss of taste or scent, which is not unusual for viral infection. It does happen with some viruses. And now we know that strange presentations can occur, like this group of young people who present with stroke. Why does that happen? I mean, that's not typical of a viral infection. Of course, now we seem to have an explanation. And as mentioned before, although there's an initial immune response to the infection, which most people cope very well, at about day 7 to 10, something happens that triggers your immune system. And unless you have what I like to call strong reserves, so a strong heart and a strong pair of kidneys, then you don't get past the lung problem. So although you're on a ventilator, which is meant to take control of your breathing and kind of allow your lungs to heal, you kind of need a strong heart and kidneys to kind of get past that. And if you have hypertension, then we know your cardiovascular risk or your cardiac reserve is less. Therefore, you are less likely to win that war, although you may have won the earlier battle against the virus. And of course, I have given data here for the Black American population in areas like Chicago, where they've had twice the mortality rate, and New Orleans. Some of my colleagues in the United States, for instance, have been alarmed. I mean, and this is interesting because as hypertension specialists, we see these disparities, but they have been magnified by this virus. And it really calls us to cause attention to it. And this slide just shows the differences in the critically ill patients. Look, 11.9% here. And this is in the United Kingdom, compared to just being 3.3% of that population there in a 2011 census. And so this novel disease really exposes a lot of known injustices, some that we've been pretending don't exist, like interventions like largely non-pharmacological public health measures aimed at flattening the curve. How do you social distance if there are about 10 or 12 people living in a small home? Or how do you social distance if you have to go to work? I mean, you may want to flatten the curve that my 3-year-old godson is talking about, but really it's unrealistic, because you may be flattening the curve and starving the next day because you don't have that kind of income. So what do you do? And so it is easy. Even this represents a bias. If someone from WHO or even the United States CDC says, well, we want to employ non-pharmacological measures aimed at flattening the curve involving social distancing, because in their environment, in their what you want to call micro population, this is what they do. They can socially distance. They can choose to work from at home. They can choose to have a Zoom meeting and still be, and still get a salary, but that's not possible in everyone. Of course, as a clinical pharmacologist, the pharmacologic interventions are a lot more exciting for me. And although a lot of them haven't been very successful, I am very much at least optimistic about the news about remdesivir, the drug that has been, has had, I'm going to say this very carefully because they haven't been published results, but out of the United States, remdesivir, which is an NIH trial, which hasn't been published, but has been reported by the director of the NIH, Anthony Fauci, who any of you who've watched CNN, even in passing, would have known him, that the results are looking good in terms of the length of stay in hospital and how your infection risk. Now here, this is my personal thought, and let me just say this is not a randomized controlled trial. I don't quite believe it's fake news either. I think that COVID-19 will evolve as a virus that requires a cocktail of drugs, and this is not unusual. If we compare things like HIV, for instance, a cocktail of drugs are used to treat it. And this is because you're kind of attacking the virus at various points. And so if you have something that decreases hospitalization by about 4 days, then if you add a second drug to it, maybe it drops it by a week. So all those kind of things are important. But other questions evolve. For instance, what about a vaccine? There are many people in the medical community who believe that we will only be living with COVID-19, as we say things like living with diabetes or living with hypertension, until there's a vaccine. Because COVID-19 now becomes a feature in our health landscape, and all we can do is suppress it to the point where you're not walking around there saying, oh, I'm really concerned about COVID-19, but you might be saying things like, oh, I was off work for about 2 weeks, I had COVID-19. And by that time, people don't even know why it's called 19 because it's so long from now. But I've had COVID-19, but I took the medication, I got over it. No one is going to shun you or worry about if you cough on them because, if you get it, so what kind of, there are drugs available. But if there's a vaccine, that changes the landscape completely. We can now be more comfortable. Interestingly, we've had some conflicting news about vaccines because initially we were told that vaccines are being tried and or immunity was lifelong. And I do believe that immunity to COVID-19 might not be as lifelong as we think it is. And it seems to be following a pattern almost like another virus that we know quite well, hepatitis B, where depending on your own immune system response, the type of infection that you've had, you may develop antibodies at different levels. So many of you have had hepatitis B titers to show that you not only have immunity, but the level of immunity that you have. So it's not just sufficient to say I have some antibodies to coronavirus 19. It's you have to show that you have a certain level. Like most infections, and this is the bad part, the degree of your antibody response usually is related to the degree of the illness that you've had. So people who've had severe infections, like near-death experiences, are likely to have a higher antibody level than if you were just an asymptomatic carrier. That's the downside of things. But other questions are there: who to test, frontliners, high-risk groups, what to test. Are we going to test PCR, which is what is currently being used to diagnose that you have an active infection? Or are you going to just do antibody testing, or are you going to do both? And what about these cases that are now re-emerging as positive cases? Are they truly positive, or is it really an artifact of the way or the test that's being carried out? You know, they use RNA, so any RNA that's detected using the polymerase chain reaction is flagged as positive. But is it positive? In other words, can that RNA really cause harm to the host that it's in? Or has that person truly recovered? How to test? Drive-through testing, mailed kits. Now here's again where discrimination is going to occur. We want to set up drive-through testing, but suppose you don't have a car. How are you going to drive through? So that eliminates a group of people to begin with. What about mailed testing kits, for instance? That might be a possibility in some areas. When to test? Do we test now? Do we test post-lockdown? Are we testing enough? Do we test indefinitely? So all those are questions we have to grapple with. And then does testing even matter? I suppose we can really only say that if we have a vaccine or a pretty robust cocktail of drugs to treat the virus. This is just a schematic showing the PCR test that's commonly done to show it's an RNA test. This is this part of the screen to the top part. No, this is not an easy test. It's uncomfortable to the patient. I dare to say it's uncomfortable to the healthcare professional as well. Having a swab stuck down into the back of your throat is not comfortable, but to the healthcare professional, removing that swab, it creates this whole mass of virus all over the place. So it's not just coming out on the swab that you think it is. So everyone in that room may be covered with, certainly the person taking the test, the entire part of the personal protective equipment or PPE is now all covered with virus. In fact, you probably have heard on CNN, most of the times when healthcare professionals get infected, it's from taking off their PPE and not necessarily being exposed by casual contact. So this is not a simple test, but it's the only test we do have for the antigen. The antibody test is a blood test. It might become in the future, who knows, a salivary test. I note that one screening test in New York, I believe, yes, it was in New York, looking at a multi-center test. It was done in people exiting supermarkets. And it showed a fairly high percentage of that population, which granted, they were probably not representative of everyone because the frontline workers are probably not in the supermarket shopping. They're probably at work. But 14% is significant. And I think that set off a red flag in the United States for two reasons. One, could more of our population actually have antibodies? And secondly, if that is the case, could this virus have been around a lot longer than we thought the index case in the United States really was? I think this graph is very important. I think it's important for every country, but I think it's more important for small island developing states such as Barbados. And that's because we don't have a lot of money to play around with, and our healthcare system can't really afford it. So first you have the first wave. And this isn't the usual flattening of the curve wave, although this is the curve that you might want to flatten, this initial purple one. This is immediate mortality and morbidity due to COVID-19, where you need ventilators. These are expensive pieces of equipment. you just can't connect a person to a ventilator. You need specialist nurses, a specialist unit. And that's the first wave, and that's what has caught all of our attention. And then there's, of course, post-ICU recovery. And I have to say, this is to varying extents. So for instance, do people return to normal post-ICU? Probably not. And then there is the second wave. Here we have urgent non-COVID patients, so people who come in with chest pain because they've had a heart attack, or weakness on one side because they've had a stroke, but interestingly, may not even want to go to the healthcare setting because they don't want to get COVID. I'm going to stay at home and bear with this chest pain. And certainly I can say at our local hospital, we've had decreases in presentations of things like heart failure, which is kind of like a normal on-call take in internal medicine. A lot of people will present with heart failure. But guess what? You're going to probably stay at home a bit more breathless than you normally would tolerate, because you don't want to go to a place that you think you're at risk of getting COVID. Then there's the third wave, where you have the interrupted care of chronic diseases. Now, I'll use myself as an example because I can't really sue myself. But so as a hypertension specialist, I have reduced my clinics, both hospital and private clinic, which means that occasionally I can have teleconferencing with patients who I think I need to keep a closer eye on. But the patients who I don't think I need to keep a closer eye on will eventually need a closer eye because I haven't seen them for a longer period of time. And so they now become the victims of the third curve, where there's interruption of care. And I'm not sure how we're going to deal with this as well, because we already have a health system that wasn't really optimized for dealing with the usual presentations of care. The third wave, notice the fourth wave, has started a lot earlier, but really extends and is going to impact all of us. We're not going to only be impacted by either having COVID-19 or knowing someone who's had COVID-19 or experiencing a loss in our family or our friends, but we will experience the economic injury, the mental health issues. This has disrupted the way we know our world to be. And as humans, we don't like to lose control of our world. I said to someone, to my neighbor actually recently, I was watching a movie recently and saw people shaking hands. And even though I know that shaking hands is a normal custom, it looked weird because this is not something that we commonly do now. And to see people shaking hands on television just looked weird. I have some myths here, but I'm not really going to go through them. I think I'm going to pause here and let Marjorie come in, because some of them are going to be triggered by your questions. So I am going to stop sharing my screen, and I hope that I have whetted your appetite. I know I'm going to take some heat for saying that sufficiently. Marjorie, over to you.
All right. Thank you very much. You have certainly shared with us quite a bit of information in that first part of our program. What I think we can now take the opportunity to do is perhaps have a discussion.